Hello everyone. As part of our Let's Talk Health program, which is conducted by Star Hospitals every fortnight, today we are here to discuss about colorectal malignancies and what are the various treatment modalities available for treating these colorectal malignancies. I am Dr. Bharat Kumar Nara. I am a senior consultant and head of the Department of Surgical Gastroenterology and Laparoscopic Surgery at Star Hospitals. And I have my colleague here, Dr. Rami Reddy. He is a senior consultant in endoscopic and medical gastroenterology. He's an interventional endoscopist. So I would also request, and today we'll talk about various aspects of colorectal malignancies and give a general awareness about how to treat these problems. Hi, Rami.
Hello.
So, Rami, this problem of colorectal malignancies, I think, is becoming very, more. We are seeing more frequently these problems nowadays in India.
Yeah.
And do you see any demographic changes
Yeah.
in this particular disease pattern?
Yeah. If you consider WHO data, this is the third most common malignancy. If you consider mortality and death rate, it is the second most common. And only demographic data, what I am observing these days is even it is initially they used to consider it as a it's a more of a old age population with multiple risk factors. But what the significant change what I observed recently is even it is a we are detecting younger age also. I mean less than 50 years also. That's why even if you consider guidelines also earlier the screening age was around 50 years. After 50 years, now that they reduced cut down, particularly USA guidelines, they cut down it to 45 years.
Correct.
That is a one significant demographic changes, and where we can by simply taking some measures, we can reduce the impact of this disease.
Correct. So when we were doing our post graduation and earlier days,
Yes.
we never encountered very young population
yeah.
having this problem.
Yes.
But nowadays it become very
The more-
frequently. We are seeing that very young people, young aged 20, 30 years
Yes,
also
even
presenting
we are
these coming with these kind of problems. So I would also ask you now, what are the common alarming signs
Yes.
where one should think about these problems?
Yes. One thing is, suppose, particularly if patient, these are a few patients are symptomatic. Not all patients are symptomatic. But if you ask for alarming signs, uh, these patients can present obvious sign is bleeding per rectum.
Correct.
And sometimes there is a altered bowel habits will be. Few people present with constipation and a few people with diarrhea and pain abdomen and significant loss of appetite and weight also. These are the common symptoms, alarming symptoms. But as I mentioned earlier, it can be completely asymptomatic also, particularly early stage. That's where role of screening will come. And otherwise, suppose unless it is advanced disease, symptoms, if disease is very advanced, suppose it spread to the liver, it can present with jaundice and pain abdomen on the right side and bony pains depending on the spread. But initial stages, if it is confined to bowel movements, these are the symptoms, particularly low hemoglobin, generalized weakness, loss of weight, loss of appetite, and bleeding per rectum, and altered color of stools also. That is.
So colorectal malignancies are a very big term, very broad term.
Yes.
So it extends from large intestine, that is, which starts from the cecum, ascending colon, transverse colon, descending colon,
in 150
sigmoid colon,
centimeters, it
and
can
also
happen.
rectum. So we are talking about a very big area of intestines.
Yes.
So do you think that the presentations will vary depending on which side where the location of the tumor is?
Yeah. See, if you consider the right side bowel, large intestine is obviously it is of 150 centimeters length, and the right side its diameter is more when compared to the left side.
Yes.
And if you take a consistency of the luminal contents also, and within the contents in the colon also, on the right side it is of more liquid state. When compared to the left side, before defecation, it will be of the more of solid state. That's why here features can differ. Suppose those patients, because it is if it is a tumors on the left side, they tend to present with a frank bleed also, but because it is a proximal to, it is very near to anal canal, they can present with a frank bleed. And it is on the left side, lumen is also narrowed, and consistency of that luminal content is very solid. They can present with obstruction also, more common. If you consider right side, obstruction is a bit less likely, even though it can occur, but it is a less likely. And and sometimes by not always these colonic tumors causes fresh frank reddish color blood. It can present with brown color and black color stools also. Particularly, it can happen in the right side of the tumors, because once blood digests in the lumen, it will come turns down into a black color. That is also one symptom.
So, two most alarming symptoms are one, blood in the stool, which is very, very, which has to be investigated, and number two, altered bowel habits.
Yes.
Suppose there is a sudden change in your habits of bowel, like you are going to toilet for once or twice in a day, and then suddenly you find that you are moving the bowels very frequently, or else if you are becoming constipated, so suddenly, so these things are should be considered as alarming signs, the most important alarming signs, apart from, like Dr. Rami said, apart from having a loss of weight and appetite and all that. So these two things should make patients to rise up to the problem. So,
and one more thing, sometimes it can be alternative also. The few days they present with constipation, followed by suddenly that narrowed part open up, they present with diarrhea.
correct.
That can also happen.
Very good. So now, having discussed these alarming symptoms,
Yes.
do you think there are any risk factors, like certain group of patients may have more incidence of having colorectal malignancies?
Yeah, definitely. One thing is age itself is a risk factor, age. And one more thing, family history of malignancies, and a few genetic disorders. They're particularly FAP, we call it, familial adenomatous polyposis
Polyposis.
coli. That such disorders will be there. And if such genetically they are predisposed, definitely they are at more high risk. And nowadays we are seeing more commonly in the background of inflammatory bowel disease also. Inflammatory bowel disease means ulcerative colitis and ulcerations in the small and large intestines, ulcerative colitis and Crohn's colitis. In that background also it can happen. These are the common risk factors what we see in the practice.
Do you think the food habits, like the present day food habits, do they influence?
If you coming to the non-modifiable thing, yes, definitely alcohol addiction, smoking, and excess processed meat, particularly the processed food, that is definitely high risk factors.
So, like Rami highlighted, so smoking, alcohol consumption, eating excessive, red meat,
Processed meat.
and processed food, and under the background of inflammatory bowel disease, colonic polyps. So these are the patients who might have increased risk. Of course, family history.
Yeah.
So
Apart from it, obesity and
obesity, yes,
obesity and sedentary lifestyle itself
correct.
increases that risk.
So, Dr. Rami, if I ask you, what is the significance of family history? So, if there is a person in the family who is affected with colorectal malignancies, what are the precautions which have to be taken by others in the family, like in terms of screening, in terms of early detection?
Yeah, generally in family history, it plays in the two roles, but because we consider the youngest diagnosis. Suppose if someone diagnosed at the age of 40 years, we start screening 5 years earlier than that age. That is a thing, and we do genetic workup. And
so you mean to say the family members around should get screened
even 5 years earlier than their detection age. And at the same time, we do screen for genetic workup also. Suppose if something comes out of it, we might start even at early age also.
stage.
Even not. Suppose if someone is positive for familial adenomatous polyposis, irrespective of the age detection age, we may start even for the kids also we do.
Correct.
That is a main.
So if there is a history of polyps in the family members, or if there is a malignancy diagnosed in one of the family members, the first degree relatives, especially the children or the siblings of that person, should undergo screening at least 5 to 10 years before the incidence of malignancy in the primary person.
Yeah.
So this is a very important thing, because the malignancy will take at least 5 to 6 years. The initial from the initial stage to develop into malignancy, it will take that much time for it to outgrow and become a malignancy. So detection for early is very important.
Right.
So this is where the screening becomes very important. I would request Dr. Rami to highlight or explain to us what are the general principles of screening in India,
Yeah.
because we know that there are protocols for Westerners like
Yeah.
Americans.
Yeah, definitely.
So as you clearly mentioned, the screening age for any American individual is 45 years.
Yeah.
Are there any specified screening protocols for Indians?
Yeah. Even though there is no such strict guideline in India, because they are in the process of making
Formulating,
Yeah, formulate. They are formulating guidelines. It takes few more years if you. But generally, in this, after 50 years, 55 years, we are definitely, if they are not symptomatic also, we are counseling them. If they are motivated, definitely they are getting it done. After 55, I can say you can go for.
So what are the common screening modalities we have?
See, one thing is to simple. If you want a non-invasive test, you can undergo fecal occult blood test. And the second thing is, if most commonly what we do and most definitive, and it has role in the treatment, is colonoscopy. Colonoscopy, I would suggest, because it not only in the diagnosis, and it helps in the treatment also for most of the early lesions.
Correct. So apart from these invasive colonoscopy and non-invasive fecal, are there any other radiological tests which are available?
CT colography is the one method, but we generally practice less in India. Correct. But these are the very cheap and.
Many patients, when I ask them to undergo a colonoscopy, they have a little apprehension about the procedure.
Then they have options of CT and fecal.
No, I want you to tell them, tell others how simple it is, or how pain-free, or how easily you can get this test done. And what are the little complications or whatever nuances are there regarding this test?
See, this colonoscopy is a very simple procedure. And initial days, definitely the anesthesia option was not there. Now we can do under conscious sedation. During that time, we'll give simple 1 or 2 injections. During that time, patients sleep for around 10 to 15 minutes. During that period, we perform the colonoscopy. It is a very simple procedure and painless, and you won't feel any pain during the anesthesia. Suppose without anesthesia, some people they don't prefer anesthesia. In such cases also we can perform, but it is a mild discomfort would be there, particularly when we inflate gas to see the colonic mucosa, intestine. That distension feeling can cause some discomfort and mild pain, and that also it can be done. But if you want, nowadays we have so many easy options where we can, without pain, we can undergo this procedure. It is very simple procedure.
So does it require an admission, or it's a daycare procedure?
No, it is a completely daycare procedure.
So a very important tool in diagnosing colorectal malignancy is colonoscopy. So like as Dr. Rami mentioned, so you will not only diagnose the problem, but also we can take a biopsy from that specimen, and sometimes there are ways to remove the tumor also completely by colonoscopy. So Dr. Rami, would you explain that to us?
Yeah.
What are the stages of colorectal malignancy where you can do entirely colonoscopic treatment?
Yeah, exactly. In early stage, particularly when carcinoma in situ, and I mean stage 1 and stage 2A also, sometimes by doing endoscopic submucosal dissection, we can perform the ESD, and we can treat the early cancers also. But otherwise, in polyp and early stages, in the low-grade dysplasia stage, we can dissect the direct polypectomy by using simple snare and the devices, or EMR, or the endoscopic mucosal dissection, or even if you feel advanced, and depending on the type of the lesion, we can do even more deeper dissection, like endoscopic submucosal dissection.
So with the advances in the technology, colonoscopy especially, so we can remove small tumors, early lesions without any major surgery through colonoscopy itself. Now coming to having said that, Dr. Rami, I would ask you, how do you stage a disease?
Yes,
Like,
sir.
so now you have diagnosed a colonic lesion
Yeah.
by doing an endoscopy, colonoscopy, and how do you next further take these patients and stage them if you have a doubt about the malignancy?
Yeah, endoscopy mainly helps us to see from inside only. But that endoscopic ultrasound for a few lesions, particularly left side lesions, yes, definitely we can see the wall infiltration. But even endoscopic ultrasound has limitations. It can't assess the distant spread.
Yes,
And that's why in such cases we have radiological investigations like computed tomography and PET CT scan. With that we can will those definitely give idea about the spread of the disease, whether it's a confined locally or it's a metastasis to other visceral organs like liver, bones, lungs.
correct. So depending on the size of the tumor, the infiltration of the tumor into the colonic wall, the spread of the tumor to the lymph nodes or to distant organs, we stage these colorectal malignancies into 4 stages: stage 1, 2, 3, and 4. So, like we have been discussing, stage 1, if the lesions are very small and if there is no lymph nodal spread or distant spread, that's stage 1. Those lesions can be managed colonoscopically. But for the rest of the lesions, like stage 1 plus 1B or stage 2 and 3 and 4, all these, I think surgery plays a major role
Yeah,
in treating these patients. So now I would also ask you, are there any blood tests which determine the, do you ask for any blood tests according along with CT scans
yeah.
or PET scans?
We generally monitor them by CEA level, monitoring carcinoma
Embryonic
embryonic
antigen.
antigen levels. That not only helps substantiate the diagnosis, it helps in the monitoring of the disease also. That is the common thing. Otherwise, we do perform routine blood test to know the general status of the patient before surgical workup.
So
That's it.
CEA is one blood test which also determines the prognosis of the patient. Does not determine the prognosis of the patient, but elevation of the CEA post procedure and pre procedure can be compared to see whether the tumor has been
Yeah,
completely
it's a monitor.
has been completely removed or not.
Yeah. Coming to your thing,
Yeah.
suppose once if I am not able to do resect in the complete resection, if it's not achievable, or sometimes few lesions, advanced lesion, I can't do anything endoscopically, then what are the various surgical options
Yeah.
available? And it is always, is it open surgery?
No. So traditionally, any malignancy of this sort, like colorectal malignancies, are treated by surgeons. I mean, surgery by surgery itself. With the, as we mentioned, with the advances in the imaging and advance in the colonoscopy, now there are certain lesions which can be removed colonoscopically or endoscopically. Even today, the major part of colorectal malignancies are treated by surgeries. So when we talk about surgeries, there are different types of surgeries which we can offer to the patient. The one and most common or older version of surgeries is a traditional surgery where it's a laparotomy where we open up the abdomen and then look for the tumor and then resect the tumor along with the segment of blood vessels
Yeah.
and lymph nodes. So this is a standard practice for doing a surgery for any colorectal
You need
malignancy.
to cut for around 7 to 10
Yeah,
inches.
we need to give adequate margins for the
Margins,
tumor. So
yeah.
we give at least a margin of 5 centimeter on either side, and also remove that part of segment of the intestine along with the blood vessels supplied to the intestinal segment, along with the lymph nodes
Yeah,
there.
patients are more concerned about outside incision. How
Correct.
length would be in
So
open surgeries.
for that reason, we have now a very advanced, sophisticated technology called laparoscopic surgery, where we don't make big scars or big cuts on the abdominal wall. We can make 5 centimeter to 10 centimeter small cuts, 4 to 5 if necessary, and then we can complete the entire procedure, entire process, like how we have been doing in the good olden days, with the similar kind of outcomes.
Yeah.
We can do very safely with laparoscopy.
Yeah, with that.
Laparoscopy will give tremendous advantages to the patient because the scar is very small, scars are very small, and the wound complications are almost negligible. and the patient's outcomes are as good as
and hospital stay also
hospital stays decrease.
less
The patients can go back to work early.
early.
In case if there is an advanced stage where they have to take adjuvant therapy following the
Cosmetically
procedure,
also it is very
very appealing. And adjuvant chemotherapy or radiotherapy if we have to add on.
yes.
So because the wounds heal very fast early, so the treatment also can be started
You can
much
start
earlier.
earlier.
Much
Okay,
earlier.
yeah, that is
So this is one advantage with the laparoscopy. Similar to laparoscopy, now we have robotic surgery also. In robotic surgery, the maneuverability is even better than laparoscopy. So we can even remove the tumors which are low lying into the pelvis very efficiently, effectively through robotic surgery. So these are very advanced, technology and instruments which we use nowadays to help patients in treating colorectal malignancies.
Yeah, one more major concern regarding a few patients is particularly always the opening will be on the abdomen. The fecal matter comes out of that. Is it there with every patient?
So you mean to say stoma?
Stoma, yeah.
Okay. So now that's a very important question. So many patients who have been diagnosed with colorectal malignancies and who are undergoing procedures, it's a common practice for even surgeons to explain to the patients that there might be a requirement for stoma. Stoma is nothing but an outlet of the for the fecal matter to come out through the abdominal wall.
Yes.
So we make an outlet from the intestines into the abdominal wall through the abdominal wall for the fecal matter to come out.
Yes.
So this is basically done for two reasons. One, when the primary anastomosis, the anastomosis means the place where we join the two ends of the resected colon. After resected colon. So once we join these two ends, depending on the day's findings, whether the anastomosis is good enough, healthy, and if the surgeon is confident enough that it will take up well, we need not do a
stoma.
Diversion stoma.
Yeah.
But for various reasons, depending on the patient factors or the surgeon's factors or the local disease factors, if you think that the anastomosis is not very good or it might have a chance of leaking later on. So that is the time when we do a proximal diversion.
Yes.
For that, so that the anastomosis will heal without much disturbances.
Yes.
And then at a later date, we can close this proximal stoma and give a natural passage for the patient.
It's not for all and not for permanent also.
Definitely not for every patient. It all depends on what stage the patient is presenting to us and which location is the tumor. So these two things are very important.
In which cases it is permanent? For few cases might be.
Yeah, few patients where the tumor is very low in the rectum.
Yes.
Which is very close to the anal sphincters, and we are not able to remove the tumor without avoiding any injury to the anal sphincters. So these are the times when we do a permanent stoma and completely.
Not every patient, no need to scare of that.
No, definitely not. So with the as I said, with the advances available for surgeons, now we can go as low as 4 centimeters to 2 centimeters down.
Ultra
low resections are possible, and then those patients can still have the functioning sphincter, and they can manage very well. And I would also like to emphasize the fact that stoma is not such a bad thing. Nowadays, the appliances which are there for applying on the stoma are very good. They are odor free. They don't stain or they don't allow the.
They can do their work easily.
Patients can very comfortably do their work. They can go to office works. They can go to any other. There are cinema movie actors who have these and they still function in the movies. So we need not worry about or take too much strain about thinking about a stoma.
You should know about the disease mapping and the prognosis and various factors involved in it. Suppose no need to scare about anything, and the stoma, it is only permanent for a very few cases. And most of the times, if it is without stoma, they are operating for most of the cases. Suppose once in a while, if they feel stoma is required, they keep it for few months only. After that, they keep it inside. There won't be any stoma, except minimal scarring will be there after laparoscopic surgery. It is very safe. Oh, what is about safety of this
Oh, it's very
laparoscopy?
safe. The success rates, I would say, are as high as 95 to 98%.
Yeah.
So even the recurrence rates, if you talk about recurrence rates, as I mentioned earlier also, the outcomes are as good as open surgery.
Open surgery.
And then the 5-year survival rates are much
Yeah.
bigger, much higher than 85 to 90%.
What are the various protocols you follow to reduce the recurrence rate?
So the first and most important thing is the tumor stage. The location of the tumor is very, very important. So suppose if you are talking about colonic malignancies, there is no prior to surgery, there is no therapy like chemotherapy or radiotherapy. We don't offer them any neoadjuvant therapy because the tumors are very amenable for resection, and then once you remove the tumor and with very good margins, so the recurrence rates are very less, and we generally add an adjuvant therapy in the form of chemotherapy following the procedure, so not prior to the procedure, depending on the stage that too. So stage 1 and some stages where some patients were even in stage 2, they do not require any adjuvant chemotherapy also following the surgery. That is for colonic malignancies. But coming to rectal malignancies is a different thing altogether. So though we club both of them as colorectal malignancies, the rectal malignancies is a different management. The management of rectal malignancies is quite different. So here the part of rectum is surrounded by very, very important structures, and it is also that there are plenty of lymph nodes which can be which can be there in that location. So for this particular problem, we generally do an MRI scan, not CT scan. So because that the staging of the problem tumor is better done under MRI than on CT scan. So once we know that this is a tumor which is having no lateral spread or no lymph nodal spread, then we can do an upfront surgery. But if there is any doubt about lateral spread or lymph nodal spread, local invasion, which we call, correct. So that for those patients, it is advisable to have neoadjuvant chemoradiation first. Neoadjuvant means before surgery. Before surgery, a course of chemotherapy and radiotherapy is given to that localized area, so that the tumor also will shrink and the margins are become better. And then
mainly downstaging.
It is a kind of downstaging and sterilizing also. It's kind of sterilizing the area also. So this will improve post-operative outcomes, the recurrence outcomes. I mean, we are talking about recurrence here. So once you do this kind of neoadjuvant chemotherapy and radiotherapy, the outcomes are better because the tumor recurrence will decrease. So this is what we have a difference between colonic malignancies and rectal malignancies. But along with these chemotherapy and radiotherapy, there are some surgical complications which can happen post chemoradiation in the form of wound healing, in the form of anastomosis healing. So that is where we would require a stoma also. That's one condition where we may require stoma.
Only they need to prepare for that.
Yes.
It might take a few more months extra.
Yes, correct.
And during you said about free margins, and how do you know whether it's a tumor is free in the intraoperatively? How do you confirm
So
it?
generally, what we as we find from the colonoscopy and CT pictures, radiological pictures, that the tumor is localized. Even on physically, when we see the tumor, we generally take the segment of the bowel. One segment of the bowel. So that segment will include at least 5 centimeters of free margins on either side. And also the colon has a typical segmental blood supply. So if you remove that segment completely, along with that, comes out the lymph nodes also. So this will ensure that particular resection is complete and it is tumor free. Of course, we always confirm this by post-surgical histopathology reports.
Intraoperatively is there?
Intraoperatively, nowadays we have advances in the form of ICG. So indocyanine green is one thing which is available. we can inject that dye and see completely where the tumor is and how the margins are.
Yeah, okay, great.
So that will also ensure our resection, and also sometimes we can also use
That
the same
guide
technology,
also.
same technology to anastomose also. It will also show us the vascularity of the segment of the bowel which we are going to anastomose.
Okay.
So this will definitely improve the outcomes.
Okay.
So the complication rates are minimized and the outcomes will improve.
Yeah, basically, colorectal malignancy is it is a very well preventable by taking simple measure by colonoscopy screening or doing fecal blood test, and it is very much treatable endoscopically without invasion also in case of early stages. Suppose if it is advanced, depending on the stage, a surgeon and team of oncologist and radiotherapy. By combining is a multidisciplinary approach, we can treat most of the cases very effectively with a good prognosis and long-term survival. And do you want to add something at the conclusion?
No, you have calculated very well. So as Dr. Rami mentioned, it's a multimodality treatment which is available for which should be given for the colorectal malignancies, and the outcomes have been ever improving from the day from last, if you take from last 15 to 20 years to now.
Yeah, definitely.
The outcomes have been ever improving with improvement in our understanding of the disease and various modalities which are available today. And I would very confidently tell that this is one of the cancers which is curable.
Yes.
When detected at right time.
Very much treatable.
Very much treatable.
And nowadays it is becoming more and more less invasive, and surgeons also more, even though they are doing very aggressive surgeries, they are doing with minimal invasive laparoscopic method. And in early stage tumors, endoscopically we can dissect them completely.
Yes. So thank you very much for being with us. I think we had a very fruitful discussion today, and we have comprehensively covered most of the things. If you have any doubts, you can always reach out to us. You can send a message and we will be happy to answer that. Thank you very much. Thank you. Thank you, Dr. Thank you.